Good morning. The topic is about laser in conservative dentistry and endodontics. Introduction. Laser is an acronym of light amplification by stimulated emission of radiation. Laser is the brightest monochromatic light existing today. After invention of laser, it has found widespread application in various fields like communication, industry, defense, and medicine. Laser are the single most important advancement in the field of endodontic, and they changed the way in which many procedures can be done. Chronology of laser development. 1971, Weishman and Johnson introduced laser in endodontics. In 1990, FDA approved laser usage in intraoral soft tissue surgery. In 1986, sterilization of root canals. In 1998, root canal shaping with ergiac lasers. Components of laser: optical cavity, an internally polished tube occupying center of the device. An active medium, it consists of chemicals that fills the core of the optic cavity. When stimulated, the active medium emits laser light. Active medium may be gas or crystal. Excitation source surrounds the optic cavity and provides energy for exciting the active medium. Optical resonator consists of two parallel mirrors placed at each end of the optical cavity. Laser light that is produced by stimulated active medium is bounced back and forth in optic cavity by the mirrors, which amplifies the light beam. Cooling unit: heat is generated as a byproduct. To dissipate the heat, air or water assisted coaxial coolant are provided in the unit. Control panel provides control over the power output. Characteristics of a laser beam: monochromatic, in other words, a single wavelength. The laser light has one specific color. Collimated, having a specific spatial boundaries and very low divergence, ensuring a constant size and shape of the beam. Coherency indicates that the light waves produced by a laser have a specific form of electromagnetic energy and are in a phase with one another. Intense in nature. Classifications of laser according to ANSI and OSHA. Standard lasers are classified to Class 1. These are low powered lasers that are safe to use. Example: laser beam pointer. Class 2, low powered visible laser that are hazardous only when viewed directly for longer than 1000 seconds. Example: helium neon lasers. Class 2B, low powered visible laser that are hazardous when viewed for more than 0.23 seconds. Class 3A, medium powered lasers that are normally hazardous if viewed for less than 0.23 seconds without magnifying optics. Class 3B, medium powered lasers that can be hazardous if viewed directly. Class 4, these are high powered lasers more than 0.5 volt that produces ocular, skin and fire hazards. Based on the wavelength of the beam, hard, increased penetration power, for example, Nd:YAG and argon. Soft tissues, decreased penetration power, for example, diode, gallium, helium neon lasers. Based on the pulsed, the beam is not continuous, that is, of shorter durations. Non-pulsed, the beam is continuous and of fixed duration. Dental laser delivery system. There are of two types of dental delivery system that is used in dental lasers. First one, hollow tube delivery system, a flexible hollow tube having an interior mirror finish. The laser energy is reflected along the hollow tube and exists through an handpiece at the surgical end, with the beam striking the tissue in a non-contact mode, that is, without directly touching the tissues. Glass fiber optic delivery system, a flexible glass fiber optic cable in a various diameter with size ranging from 200 to 1000 nanometer. Although the glass fibers is encased in a resilient sheath, it cannot be bent into a sharp angle. This fiber fits into a handpiece with the bare end protruding. This system can be used in both contact. Quartz fiber, the ideal delivery system as it is cheap and easily sourced. It is applicable to UV, visible, and near wavelengths. High water absorption by longer wavelength precludes its use in the erbium due to hydroxyl group present in the quartz. Higher wavelength of the mid and far infrared used in germanium oxide, zirconium fluoride, sapphire, hollow silica with external cooling of the air and water as a delivery mechanism. Fiber size is an important consideration in deploying a beam of delivery system. Smaller fiber produces a less degradation of beam quality. Using a smaller fiber, assuming the same numerical aperture, allows the same focused spot size to be achieved with a greater standoff distance or alternatively smaller spot size to be achieved. Laser wavelength used in dentistry. CO2 laser, gas active medium laser, hollow tube like waveguide, continuous or gated pulse mode or pulsed mode, wavelength 10,600 nanometer, well absorbed by water. Rapid soft tissue remover and has a shallow depth of tissue penetration, which is important when treating mucosal lesions. Beam can be focused to create a precise coagulation of smaller blood vessels. Principle: CO2 plus energy gives CO plus O minus, resulting molecules no longer able to produce the CO2 laser. This degrading nature of CO2 brought several developments in CO2 lasers. Nd:YAG has a solid active medium, a crystal of yttrium aluminum garnet doped with neodymium. Wavelength 1064 nanometer. Fiber optic delivered in a free running pulsed mode, most often in contact with the tissue. First, laser designed exclusively for dentistry. Highly absorbed by pigmented tissue and is about 10,000 times more absorbed by water than an argon laser. Common clinic application are of cutting and coagulation of a dental soft tissue with a good hemostatic capability. Diode, a solid state semiconductor laser that is used a combination of aluminum, gallium and an arsenate that converts electrical energy into light energy. Wavelength 800 to 980 nanometer. Fiber optically delivered in a continuous or pulsed mode and is used commonly in contact with tissues. Poorly absorbed by tissue structures like tooth structure. Hence, soft tissue surgery can be safely performed in close proximity to dental hard tissues. Advantages of being compact, portable, and economical. Argon. Active gas medium containing argon. 2 emission wavelength. 488 nanometer blue in color. 514 nanometer blue green in color. Delivered through a fiber optic system in a continuous as well as pulsed mode. The 488 nanometer emission is the exact wavelength needed to activate camphoroquinone. This laser is used to cure light activated composite, light activated impression material, and light activated bleaching cells. The 514 nanometer wavelength has the highest absorption in the hemoglobin and is used for its good hemostatic capability. ERGIAC and ERG-CR-ISGG. It has an active medium of a solid crystal of yttrium, scandium, gallium garnet that is doped with erbium and chromium. ERGIAC has an active medium of a solid yttrium aluminum garnet that is doped with erbium. Both are delivered fiber optically in the free running pulse mode. Tissue responses to lasers. The light energy from the laser beam can have different interaction with the target tissue depending on two principal factors. One is wavelength of the laser used, two optical property of the target tissue. These two variables determines the following responses. Reflection. The laser beam reflects or redirects itself away from the tissue surface and have no effect on target tissue. Absorption. This depends on tissue characteristics such as water content and the level of pigmentation and on a laser wavelength and emission mode. Transmission. There is no effect on target tissue since it transmits a laser energy through itself. This depends on the wavelength of laser employed. Scattering. This process weakens the energy of the beam and produces no useful biological effect. Scattering can cause heat transfer to adjacent tissue and consequent thermal damage. Laser effects on tissue. The light energy from the laser can have four different interactions with target tissues: photochemical interaction, photothermal interaction, photomechanical interaction, and photoelectrical interactions. Photochemical interaction. These are certain wavelengths of a laser which was observed by naturally occurring chromophores and induce certain biochemical reactions. Biostimulation, a stimulatory effect of laser light on biochemical and molecular process that induce healing and repair of the tissue. Photodynamic therapy, which is a therapeutic use of laser to induce a reaction and produce biochemically reactive form of oxygen. This oxygen disturbs the membrane of microorganism. Example: toluene chloride under 635 nanometer laser gives oxygen. Photothermal interaction, photoablation or removal of the tissue by vaporization and superheating of the tissue fluids, coagulation and hemostasis, photopyrolysis or the burning of away of the tissues. Type of thermal reaction depends on spot size, power density, pulse duration, pulse frequency, optic property and composition of radiated tissue. Photomechanical interaction, non-thermal interaction produced by high energy short pulsed laser light. Photodisruption, shock waves by laser rupture the intermolecular and atomic bonds. Photodissociation, which is the breaking apart of structure. Photoacoustic interaction, a shock wave explodes and pulverizes the tissue and produces a crater. Photoelectrical interaction, photoplasmolysis, tissue is removed through the formation of electrically charged ions and particles that exist in a semi-gaseous and high energy state. Laser and hard tissue interaction. Absorption and transmission depends on the wavelength of laser. Laser causes zones of carbonization, necrosis, and induce crack in the enamel. Steam pressure buildup in the dental tissues and explosive expansion takes within the surrounding hydroxyapatite. This process leads to surface holes or craters on the surface, and hydroxyapatite has been vaporized. This thermomechanical effect is very efficient in removal of hydroxyapatite in the hard tissue. To prevent the pulpal damage by thermal effect of laser air water spray is used. It produces cooling effect on the dental pulp, wash away the debris, keeping the area moist and prevent drying of the tissues. Advantages: it reduces the need for anesthesia, greater comfort during and after surgery, hemostasis and reduced risk of blood-borne pathogens, high patient acceptance, reduced stress and fatigue for practitioner and staff, produces less collateral thermal damages than with an electrocautery. Limitations: all laser requires specialized training and attention to safety precaution, slower than traditional methods. No single laser can perform all desired dental applications. Clinical applications of laser. Clinical applications of laser in conservative dentistry. It includes cavity preparation, diagnostic lasers, restoration removal, etching, photopolymerization, caries prevention, laser desensitization. Clinical applications of laser in endodontic includes pulp vitality assessment, pulp capping and pulpotomy, disinfections of root canal, obturation and apical surgery. Diagnostic and curing laser. The Diagnodent is used for caries and calculus detection by emitting a non-ionizing laser beam at a wavelength of 655 nanometer at 900 angle towards a specific darkened groove on the occlusal surface of the patient's tooth where bacteria decay is suspected, or along the longer axis of the root surface to detect the presence of bacteria-laden calculus. This diagnostic technology, in which the photons of this laser wavelengths are absorbed into any existing bacteria in these areas of patient's tooth, is called laser-induced fluorescence. The instrument's digital display indicates the number of bacteria in this area of the tooth, and it may correspond to extent of decay of the existence of a calculus. A diagnodont is a pen-like probe that sends a safe, painless laser beam into the tooth. The numeric display and the alarm signal when there are signs of hidden decay. Cavity preparation. Cavity preparation by using laser have been an area of major research interest ever since laser was initially developed in early 1960s. At present, several laser types with similar wavelength in the middle infrared region of the electromagnetic spectrum are commonly used for cavity preparation and caries removal. The ergiac laser was tested for preparing dental hard tissues for the first time in 1988. It was successfully used to prepare holes in the enamel and dentin with low fluorescence energy in a unit of joule per centimeter square. Even without water cooling, the prepared cavity shows no crack and low or no charring, while the increase in mean temperature of the pulp cavity was about 4.3 degrees Celsius. In 1989, it was demonstrated that the ergiac laser produced cavities in the enamel and dentin without any major adverse side effects. Restoration removal. The ergiac laser is capable of removing cement, composite resins, and the glass ionomers. The efficiency of ablation is comparable to that of enamel and dentin. Laser should not be used to ablate the amalgam restoration. However, because of the potential release of mercury vapor, the ergiac laser is incapable of removing gold crowns, cast restoration, ceramic materials because of the low absorption of these material and the reflection of the laser light. This limitation highlights the need for adequate operator training in the use of lasers. Etching and photopolymerization. Etching. Laser etching has been evaluated as an alternative to the acid etching of enamel and dentin. The ergiac laser produces microexplosion during hard tissue ablation that results in microscopic and macroscopic irregularities. These micro irregularities make the enamel surface micro-retentive, and they may offer a mechanism of adhesion without acid etching. However, it has been shown that the adhesion to the dental hard tissues after ergiac laser etching is inferior to that which is obtained after conventional acid etching. Photopolymerization. The argon laser is one promising source as the wavelength of the light which is emitted by this laser is optimal for the initiation of polymerization of the composite resin. The argon laser at 488 nanometer blue is used. The argon wavelength activates camphor quinone, a photoinitiator that causes polymerization of the resin composites. The argon laser radiation is also able to alter the surface of chemistry of both the enamel and the root surface dentin, which reduces the probability of the recurrent caries. Caries prevention. Controversial results can be found in literature regarding the demineralization and the acid resistance of enamel and dentin after ergiac laser treatment. An increased temperature is necessary to achieve photothermal effect and the enhancement of the enamel acid resistance. According to Fried et al. 1989, the energy density which is necessary to reach the enamel acid resistance by using the RCR YSGG laser is approximately 8 to 13 joule per centimeter square. This is expected to decrease the enamel solubility by promoting the thermal decomposition of the more soluble carbonate hydroxyapatite into the less soluble hydroxyapatite, with corresponding changes in its crystallinity. Laser desensitization. Dental hypersensitivity is the most common complaint in the dental clinical practice. Various treatment modalities such as application of concentrated fluorides to seal the exposed dentinal tubules have been tested to treat the condition. However, the success rate can be greatly improved by the ongoing evaluation of the laser in hard tissue applications. A comparison of desensitizing effects of an ERG laser with those of conventional desensitizing system on a cervically exposed hypersensitive dentin showed that the desensitizing of hypersensitive dentin with an ERG laser was effective, and the maintenance of the positive results was more prolonged than with other agents. Pulp vitality assessment. Traditional vitality assessment methods such as heat, cold, and electric pulp tester assess neural vitality and often causes false positive errors. As the histologic assessment of the pulp status is not feasible clinically, a tool to assess vascular flow of the pulp would be very useful. Laser Doppler flowmetry is an accurate method to assess blood flow in the microvascular system. A diode is used to project an infrared light beam through the crown and pulp chamber of the tooth. The infrared light beam is scattered as it passes through the pulp tissue. The Doppler principle states that the light beam will be frequently shifted by moving red blood cells but will remain unshifted as it passes through the static tissues. The average Doppler frequency shift will measure the velocity at which the red blood cells are moving. Pulse oximetry. Pulse oximeter is used to determine the pulpal blood flow by measuring the oxygen concentration of the blood and the pulse rate. The device used for pulp testing are too bulky and complicated to be used on routine basis in a dental practice. Pulp capping and pulpotomy. Pulp capping and pulpotomy constitute a more conservation form of pulp therapy in comparison to pulpotomy. Although the outcome of pulp capping procedure is variable ranges from 44 to 97%, the procedure is recommended when the exposure is 1 millimeter or less, or especially when the patient is young. Pulpotomy is recommended in immature permanent teeth where pulpectomy is not advised. The use of laser in these procedures leads to a potentially bloodless field, as the laser has an ability to coagulate and seal small blood vessels. The laser tissue interaction make the treated wound surface sterile and also improve the prognosis of the procedure. Wound healing of the irradiated pulps seems to be better than that of controls. Indirect pulp capping. In case of deep and hypersensitive cavities, a reduction in the permeability of the dentin achieved by sealing the dentinal tubules. Pulpotomy and vital pulp amputation, one of the most anticipated laser treatment in endodontic. Carbonized layer that is formed on the surface must be removed with 3% hydrogen peroxide and 3.23% of sodium chloride. Disinfection of a root canal. The ability of the bacterial pathogens to persist after shaping and cleaning is one of the main reasons for endodontic failure. This is attributed to complex nature of the root canal system, the presence of smear layer, and the fact the large areas over 35% of canal surfaces area remains unchanged following instrumentation with nickel titanium technique. Studies have assessed the role of CO2 and Nd:YAG laser in root canals and found evidences of the dental tubules in disinfections. Other lasers such as xylem chloride laser, ERYSGG and ERGIAC diode, Nd:YAG and organ have been used for this purpose. This laser is delivered into the root canal system with the help of a thin fiber optic, as in case of Nd:YAG, ERYSGG, argon diode lasers. A hollow tube is employed for this purpose in CO2 and ERGIAC lasers. The laser beam that is emitted from the tip of the fiber optic is directly vertically downwards into the root canal and not laterally into the dentinal tubules. This is further compromised by inherent curvature present in the root canals. Thus, it is not possible to laser irradiate all the dimensions of the canal system completely. The other concern raised was inadvertent transmission of the laser into a periradicular region while irradiating the apical third of the root canal system. It is potentially dangerous in the areas around the apices of the teeth close to mental and mandibular foramen. The development of side-firing spiral tip with an ergiac laser is an effort to overcome this hazard. Most researchers conclude that laser irradiation is the effective method to kill microorganisms. It can act as an adjunct to the traditional mean of shaping and cleaning. Obturation, thermoplasticized gutta percha obturation system are one of the most effective method and efficient in achieving the fluid impervious seal. Softening of gutta percha has been attempted with various lasers. These includes argon, CO2, NDAC and ergiac. Apical surgery. Apical surgery, including apical resection is indicated when the previously performed root canal fails and non-surgical means are inadequate to ensure the complete removal of the pathogenic process. The potential for using laser is on the basis of following observation: ability of laser to coagulate and seal small blood vessels, thereby enabling a bloodless surgical field; potential of laser ergiac to cut hard dental tissues without causing elaborate thermal damages to the adjoining tissues. Clinically, the use of this type of laser improved healing and patient reported reduced discomfort. Conclusion: although numerous studies have proved the efficacy of laser in endodontic application, acceptance of this technology by clinicians is limited. This could be attributed to the high cost of technology and the need for more than one laser frequency to cover all endodontic application. The future for laser in endodontic is promising with rapid development of thinner and more flexible fiber optic delivery system with an improvement in our knowledge of optical laser parameters. Once our knowledge of the optical laser parameter for each treatment modality is complete, laser can be developed that will provide dentists with ability to care for a patient with improved techniques and equipments. Thank you.